Good afternoon, everybody, and welcome to the WeMove Adolescent Health webinar hosted by the Desmond Tutu Health Foundation and the International AIDS Vaccine Initiative, or IAVI. My name is Bronwyn Kutsia, and I'm a senior lecturer in the Department of Psychology at Stellenbosch University, and I will be chairing the session this afternoon with all of our esteemed speakers and panelists who are joining us. So thank you very much for joining us today. We're looking forward to this interesting and interactive session. This is the fourth webinar in the WeMove series, and today we're focusing on living long with HIV. So we'll hear talks from Professor Elona Toska and Dr. Nicolette Comley-White, in between which we'll have an artistic interlude from Dshamilja Roshani, and this will be followed by a panel discussion where our speakers will be joined by Professor Lesley Gittings, Theresa Mapfuti, and Dickson Madzivadondo. Dickson, I hope I said your surname correctly for the discussion. The topics in today's webinar, which are very interesting, is supporting adolescents with HIV to survive and thrive in a complex world, insights from Southern Africa. And our second topic will be living long with perinatal HIV. Where are we in adolescence? So to start off with, we'd like to know a little bit more about what you think about these two timely and important topics. And we've set a quick poll question. Let me just see if I can see it on my side. But you should be able to see a poll question come up, and that poll question will read, what do you think is the most critical support or service that adolescents living with HIV in Southern Africa need to thrive in their communities? So there's a number of response options there. And then we have a second question as well. What are the primary challenges that adolescents living with HIV face in terms of long-term health and well-being? So let me give you a couple of minutes to make your selections there, and then we can have a look at the responses. I'll give it about another minute or so, and so people can let us know what they think here. We've just about had everyone respond. Let me give it about 20 or 30 more seconds. Let's see if there's a few more. And thank you to everyone who's joining. For those of you who've just joined us, we're completing a poll. So you'll see that pop up on your screen. There'll be 2 questions there. Please let us know your answers. I'll give it about 10 more seconds or so, and then we'll have a look. All right. Thank you, everyone, for participating in the poll. I trust you found that enjoyable and interesting and somewhat thought-provoking. And let's see what people have said. So the first question was around, what do you think is the most critical support or service that adolescents living with HIV in Southern Africa need to thrive in their communities? And I think by far people think that a supportive family and community environment is what adolescents need, and thereafter mental health support and access to healthcare. So when the poll first began, I noticed that there weren't many response options towards access to healthcare, but I'm glad to see that that's sort of picked up in this particular question, and agree with the supportive family and community environment. So very interesting. Thanks for that. Our second question was, what are the primary challenges that adolescents living with HIV face in terms of long-term health and well-being? And we can see that some of the primary or the main challenge identified by most of our participants here this afternoon is stigma and discrimination. And I think we can agree that that continues to be a salient issue, as is medication adherence and mental health issues. So thank you, everyone, for participating in the poll. I think it sets us up nicely for the presentations that are to come. All right. So you'll notice that for the time being, you've been muted, but please do leave your comments in the chat. And when we commence the panel discussion, we will allow for people from the audience to participate in the conversation this afternoon. So to get things going, it is my absolute pleasure to introduce to you our first speaker this afternoon, which is Professor Elona Toska, who is an adolescent health researcher and the director of the Adolescent Accelerators Research Hub at the Centre for Social Science Research at the University of Cape Town. She's the co-principal investigator, along with Professor Lucy Kluwer, for the UKRI GCRF Accelerator Hub. She's also the co-PI of several large studies, including Mzansi and the Uplift study, which is the study on understanding the predictors of lifelong initiation and follow-up treatment for adolescents and youth living with HIV. Other studies that she's co-PI on is the Helping Empower Youth Brought Up in Adversity with their Babies and Young Children study, which is wonderfully titled the Hey Baby Study on adolescent mothers and their children. And then she's also involved in the Screen and Support Package and the Teen Advisory Groups. The title of her talk this afternoon is Supporting Adolescents Living with HIV to Survive and Thrive in a Complex World, and her insights from Southern Africa. So thank you very much, Professor Toska. Over to you.
Thank you very much for having us today. We are delighted to share with you research and insights on how we can support adolescents living with HIV survive and thrive in a complex world, primarily focusing on insights from South Africa and the region. Dr. Tabi Sianaijo, Dr. Lesley Gittings, and I will present in 3 parts, and we look forward to hearing your feedback. Before diving deeper into the research and the evidence that we want to share with you, we wanted to acknowledge a tenet, a principle that has guided our work and that of many of those in the panel and in the audience. Particularly in the case of adolescents and young people living with HIV, all of our work engaging with them in trying to understand their age and life stage appropriate needs, experiences, and the solutions we can generate for and with them is driven by the principle of nothing for us without us. During our talk, we'll do a bit of a whirlwind tour of a lot of insights and research that we have been conducting for over a decade, and that of some of other colleagues in the region. First, Sia will present on his analysis and that of Professor Lucy Kluver on adolescents living with HIV more broadly, their adherence, viral suppression, and what we can do to support them. Then I will share some insights on adolescent mothers living with HIV and their children. And finally, Lesley will share insights specific and unique to adolescent boys and young men living with HIV from her research, and she will be available at the panel for any comments and questions. Over to you, Sia.
Thank you, Elona, and hello, everyone. Thank you for this opportunity to present to you. Ladies and gentlemen, allow me to acknowledge the significant progress we have made in reducing HIV-related mortality and morbidity. However, despite these reductions, adolescents continue to experience disproportionately poor health outcomes compared to other age groups. Therefore, the next few slides are going to demonstrate some of this evidence as adolescents grow with HIV. To do this, we are going to use data from a longitudinal mixed method study which was conducted among adolescents living with HIV. This data comes from about 1,046 adolescents living with HIV who were aged 10 to 19 at baseline, recruited and interviewed 3 times in the Eastern Cape province of South Africa between the years 2014 and 2018. Several studies have reported lower adherence rates among adolescents living with HIV compared to adults and children. However, evidence on long-term sustained adherence among adolescents living with HIV remains scarce. Using this data or the data we mentioned above, we investigated sustained adherence using a measure of past week adherence. Sustained adherence was defined as the proportion of adolescents who reported past week adherence consistently over the 3 waves or 3 data points. And essentially in this study, we found that only 37.1% of adolescents had sustained adherence after 4 years of follow-up. And these results demonstrate that non-adherence is still a major risk among adolescents living with HIV, and therefore efforts to support adolescents take their medication or their ART medication are urgently needed. Given the lower rates of adherence among adolescents compared to other age groups, we also investigated the impact of sexual violence on self-reported adherence among adolescents living with HIV. In this study, sexual violence was measured based on experiences of sexual abuse and intimate partner violence. Our data showed that 11% of the sample reported exposure to both IPV and sexual abuse within the past 2 years. Our analysis further demonstrated that sexual abuse and intimate partner violence were strongly associated with reductions in ART adherence among both adolescent boys and girls. These findings suggest an urgent need to link violence prevention to HIV care services for adolescents living with HIV. To take our work on adherence further, in this current analysis, we sought to identify and describe longitudinal patterns of ART adherence among adolescents using trajectory analysis. And to achieve this, we used 5 self-reported measures of adherence validated against viral load to fit a group-based multi-trajectory model. Essentially, in this analysis, we found 4 distinct trajectories describing adherence behavior over the 3 data points among adolescents living with HIV. And the first group, which is green, We termed it consistent adherence, and this is the group of adolescents who start high on adherence and consistently report taking their ART based on all the 5 self-reported measures. And the second group is the increasing adherence who start low but improve over time. And the third group is decreasing adherence, which is in purple. They start high and gradually decrease over time. And the fourth and last group is the low and decreasing adherence trajectory, which is red in color. And these are consistently non-adherent based on all the 5 self-reported measures. These trajectory groups differed significantly by age, sex, place of residence, poverty, and mode of HIV acquisition. For example, older female adolescents who acquired HIV sexually were more likely to follow the trajectory in red, which is the low and decreasing adherence trajectory. Lastly, we also found that the rates of viral suppression were significantly lower in all other trajectories compared to the consistent adherence trajectory. Previous research shows that mortality among adolescents living with HIV remains high compared to other age groups. Therefore, at the end of follow-up of our cohort, we sought to describe all-cause mortality among this cohort of adolescents, and the results are shown above. For example, the proportions of reported deaths among adolescents living with HIV was 8.7% compared to 0.4% among their HIV-negative peers. And proportions by sex among adolescents living with HIV was 10.7% for males compared to 7.1% for females. Our results demonstrate that all-cause mortality is still a persistent issue among adolescents by sex and HIV status. In particular, adolescents living with HIV remain at high risk compared to their HIV-negative peers. There is evidence on the potential of cash plus care support programs to reduce gaps in HIV care, and most of this evidence comes from randomized controlled trials. Using the above-mentioned self-reported data and viral load data for the adolescents obtained from the National Health Laboratory Services of South Africa, we investigated the impact of government-provided social protection and family-related psychosocial support on viral non-suppression among adolescents living with HIV. And in this analysis, we found that a combination of government-provided social protection and family psychosocial support could substantially reduce viral non-suppression among adolescents as they grow. And this is demonstrated in the figure above. We also know from previous research that tailored clinic or health service provision is crucial to supporting adolescent girls and young women living with HIV. However, there's little evidence on which healthcare provisions may maximize or drive key HIV-related outcomes among this population group. Following our investigation or analysis, findings from our cohort data showed that access to safe and affordable HIV care and adolescent responsive services may lead to improved HIV-related health outcomes among adolescent girls and young women, as demonstrated in the graph above. In this study, we sought to identify accelerator provisions associated with multiple outcomes linked to SDG-aligned targets among adolescents. We defined an accelerator as a factor or provision that has positive impacts across targets of several SDG goals. For a highly vulnerable group of adolescents, we found locally effective accelerator provisions that have positive impacts across multiple SDG goals and targets that include and reach beyond health. In this analysis, we found that access to safe schools, parenting support, and government-provided social protection had more positive impacts on improvement in a wider range of SDG-aligned targets. The figure above shows that access to all these 3 accelerator provisions resulted in improvements that go beyond HIV to include improvements in school progression and reductions in violence. Thank you for listening. I'll hand over to Elona.
Thank you, Sia. For the next few slides, we will share insights on the lives and experiences of adolescent mothers living with HIV and their children. Some of our initial analysis tried to understand how access, uptake of contraception and condom use was amongst adolescent girls and young women in South Africa, comparing 4 different groups: adolescent girls and young women who had not had children and were not living with HIV, those who were living with HIV and had not had children yet, in blue in these 2 graphs, and then in red, in the red lines, adolescent girls and young women who had become mothers, including both those who were not living with HIV and those living with HIV. This is quite a complex graph, so just to summarize, that on the left are rates of hormonal contraception, on the right rates of condom use, and what we see is a flip. Adolescent girls and young women, the line in red, are more likely to use hormonal contraception and less likely to use condom use, but these rates remain low whether it is the hormonal contraception or condom use throughout. And we see a little bit of an impact of HIV, with adolescent mothers living with HIV having slightly lower rates of hormonal contraception, slightly higher rates of condom use than the other mothers, indicating really the need for us to think about how do we support increasing access and utilization to sexual and reproductive health services for all adolescent girls and young women who become mothers, including those living with HIV. We then had colleagues looking at the mental health experiences in the context of motherhood and HIV, and looking again at these 4 subgroups, would see that adolescent mothers living with HIV had the highest rate of reporting any common mental disorders. So this is symptoms of depression, anxiety, trauma, and suicidal ideation or suicidality. And this is for many complex reasons, including stigma and mental health challenges linked to both pregnancy, as the quote at the top shows. Just having a pregnancy bump and a child can be quite stigmatizing in some of the communities young people live, but also with regards to managing the experiences of disclosing and learning about HIV status, which are very complex and hard as one is growing up. Our colleague Bolade Banunyo looked at this effect of combined experiences of motherhood and living with HIV when it came to school-related outcomes. And here we see rates of non-enrollment in school, so being out of school and not having a job. And we see that mothers, adolescent mothers living with HIV, were much more likely to experience higher rates of school non-enrollment, really indicating a potential joint effect, a syndemic effect of motherhood and HIV. And we're still trying to understand why this is. It could be because having a child makes you more likely to get sick while we're living with HIV. Returning to school is that much harder. But it's really important to think about how do we support this cohort of young women living with HIV in our communities, not just do well health-wise, but also complete their schooling. And then looking forward towards their sexual and reproductive health experiences and their children, we wanted to understand experiences of pregnancy, motherhood, and service access during this critical stage in adolescent mothers living with HIV. And what we see is that already they were likely to have multiple children. So supporting them with remaining in care and treatment after their first child and throughout their life is a really important element. You'll see here that more than nearly 3/4 had their child tested before they're 2 years old, but that's still a quarter that needs access to testing. And even though we haven't yet verified this with the laboratory data, 5% of the mothers told us they had at least 1 child living with HIV, which is higher than the national rate in South Africa. Luckily, we have really inspiring programs. This is one example from Zimbabwe of the Zvandiri Young Mentor Moms program, and thank you to the team for sharing some of their early data with us. And what is here is the viral load cascade for their young mothers, and we'll see that it's a really solid cascade with support by young mentor moms. Viral suppression rates were really high throughout for young mothers living with HIV, and particularly their early EID rates were 92% compared to 72% in the Zimbabwe national data. And their mother-to-child transmission rates, the vertical transmission, is 1%, much lower than the national rates of 8%. So really we want to have similar programs throughout for all young women living with HIV and their partners.
Hello, my name is Lesley Gittings, and I'm an assistant professor at Western University in Canada and a research associate with the Adolescent Accelerators Hub at the University of Cape Town. I'll be presenting on qualitative research conducted between 2015 and 2022 with the studies introduced by Dr. Toska. This research aimed to understand health experiences and practices of adolescent boys and young men living long with perinatally acquired HIV. This is important because even though women and girls are more vulnerable to HIV acquisition, men seek treatment less and later and are more likely to disengage from the HIV cascade of care and die of age-related illness. Here you can see an adolescent boy creating an art-based life history narrative. A common experience, like shown here, is that participants experienced severe illness as children, tested positive for HIV, and then got better after starting ART. Through these early challenges, they learned how to navigate the health system, came to trust in the efficacy of ART, and developed supportive relationships with health workers. This might be a reason why boys living with perinatally acquired HIV have lower mortality than those who acquire HIV later on. Hello, my name is Lesley. Another finding was that participants wanted to get married, have children, and be present fathers, in contrast to their own fathers, who are unable to be there for them because of age-related illness or poverty. The example here of boys' dreams for the future was common. You can see it has the words "having a lovely family" accompanied by an image of a happy family with a sizable home in a leafy suburb. Given that living with HIV is still perceived as a barrier for men to have intimate relationships, children, and breadwin, achieving these dreams represents their survival and becoming the successful men that their fathers couldn't be. Despite wishing for these things, many of the boys in our study could not achieve them because of structural violence and poverty. Because they didn't have other signifiers of masculinity, they were extra vulnerable to HIV-related stigma. Another finding was that participants wanted to get married. HIV-related stigma may affect women and men differently, given that masculine norms require men to act tough and repress vulnerability and illness. As boys became older, stigma became a barrier to accessing health services, and they described being afraid of going to the clinic for fear that people would learn of their HIV status. Some health centers had a separate waiting area, similar to the one seen here for people taking chronic medication. Other clinics color-coded their folders. And these practices deterred participants from going to the clinic because they felt visibilized and stigmatized. And this was especially true when they stopped being accompanied by a caregiver, which happens earlier for boys than girls. Girls and women might also not feel as visibilized because it is common for them to attend the clinic for reproductive health services. In summary, what we found is that while boys gained skills as children to navigate the health system, as they got older, masculinity-related deterrents began to shape their health practices, and many disengaged from care. A key takeaway is that considering the needs of boys and men living long with HIV is important, while of course not losing focus on the important needs of girls and women. HIV-related.
In summary, our work, combined with that of colleagues from the region and many of you implementing programs for and with adolescents and young people living with HIV, has identified several components that are critical to not just managing and surviving and thriving while living with HIV, but also doing well in other domains of life. And these include supporting young people to access health services and facilities, whether by making facilities more accessible through mobile clinics, peer-based models, providing responsive and respectful care that acknowledges their life stage, different age needs, but also the way where they are with managing their HIV status disclosure, understanding, and stages that and support they may need. Supporting their peers, caregivers, and partners to provide the psychosocial support that they need, particularly thinking about the caregivers of these adolescents, and including adolescents when they become parents themselves. And not to forget, last but not least, economic and livelihood support, because all of this cannot be possible when someone is hungry or stressed out and unable to provide for themselves, their children, or their families. Thank you for having us. Feel free to contact us in any of our email addresses here. Thanks, everyone.
Thank you so much to all of our speakers for the wonderful presentation, which I'm sure the panelists as well as the audience are eager to engage with, which will be later during the panel discussion. As I understand it now, we'll have a short sort of interlude here by the artist Dshamilja Roshani, who is a Berlin-born poet, writer, and performer of German-Iranian descent, who is based in Johannesburg, and their work explores themes such as queerness, home, and belonging. It was featured on the international platforms such as Poetry Africa, Button Poetry, Word and Sound, Decolonized Festival at the Joburg Theatre. And their debut album, The Pride of Water, was released in March of this year. And they'll be sharing a poem entitled Beneath the Cover. Thank you so much.
Hi, my name is Dshamilja Roshani. My pronouns are they, them. I'm a poet, writer, and performer based in Johannesburg. You can find me on all social media platforms as Dshamilja Roshani. Some of my work is on Spotify as well, so feel free to check that out. I'm going to read you my poem, Beneath the Cover. There's a book on my table that demands to be read. Its cover depicts a swallowing shame. Its pages reek of cold hospital beds. Its title is spelled in panic disdain. Its spine casts lifelong shadows of dread. Its author was unknown for years, while reviews spoke of infinite sequels. With fingers shaking from handed-down fear, I open the book. Chapter 1. There's a girl who just turned 16, but fears for the rest of her life. At the clinic, they say she harbors death in her blood, an enemy she cannot see. She wants to tell her mother, but her lips remain sealed by disgrace. Each heartbeat the sound of a time bomb, ticking in her own ears. Chapter 2. There's a middle-aged man of shallow conscience whose pockets are open and deep. The girls he kisses in public only ever stay for the weekend, long enough to feed his hunger for peaches. Why spend money on condoms when he pays for her school fees? Chapter 3. There's a child that is yet to be born, but already carries a burden. The parents, too young and careless for tests, will spend the rest of their lives asking for pardon. Chapter 4. There was a woman, a queen, a trailblazer, who threw stones at the walls of injustice. Revered by her kind, reviled by the world, she paid their gazes no mind. When the disease intruded her body too, it only ever strengthened her vision. The words she spoke, the walls she broke, the bricks she laid down, the dreams she evoked, still paved the road to our freedom. Chapter 5. There's a nurse, exhausted by purpose that never seems to run dry, holding hands and pricking fingertips, trading knowledge for fear all day, bargaining for each added year. She may not know how to beat this virus, but she knows perfectly well how to weaken its grip. Chapter 6. There's a young man with fidgeting fingers, waiting for results with a tightened throat, frightened of death but more so of judgment. When certainty comes, his future crumbles, the ground swept away by a flood of questions, too much knowledge abbreviated, ART, TLD, CD4, words he never heard before, the nurse's soft voice, the only life ring in sight. She says the seas will stay calm, the future still yours with your dreams by your side. All that it takes will be one daily pill for the rest of your life. Chapter 7. There's a girl who we know from chapter 1, now grown into a woman. Her health in best shape and her mind even sharper, the youngest doc in the research department. Her colleagues adore her, her mother so proud. Her friends ask her out, but she's glued to her desk. She never regrets all the weekends indoors, for there's no company like these pages. Back then, when the pills kept her body alive, it was knowledge that silenced the shame in her mind, infusing hope in her veins. Now it is time to pay back. Bent over books and research papers, her mind stacked to the brim with stem cells and stats, transplants and samples and obscure mutations, a solid foundation for her groundbreaking aim. As brick by brick, she develops a cure. I turn the last page, then close the book. I take a deep breath. The title reads less frightening now. The cover feels less unsettling. I find that my hands have stopped trembling. I breathe in again. Then I pick up the pen.
Colleagues, I'm in no position to comment on poetry, but that was such a powerful and moving delivery. Thank you so much, Dshamilja. I feel as though we all need to take that deep breath that she was encouraging there at the end, that they were encouraging. Sure. Okay. Our next speaker is Dr. Nicolette Comley-White, who is a physiotherapist by training, working at the University of Witwatersrand in South Africa, and she's a senior lecturer there and recently completed her PhD in the field of adolescent HIV. And her PhD study was a mixed method study, and her findings were used to create a model of care for screening of adolescents with perinatal HIV. And she aims to continue the research project in other geographical areas, both within South Africa as well as other Southern African or Sub-Saharan African countries. And her presentation title is Living Long with Perinatal HIV, Where Are We in Adolescence? Dr. Comley-White, are you comfortable with delivering your presentation live, or would you prefer the recording? I see some of our audience members have issues with sounds this afternoon, so do let us know.
I'm happy to do it live. That's fine. I believe that DTHF will present it. So if everyone can see, then I'm ready to go. How's the sound now that it's live? Is it better?
On my side, it's perfect. Colleagues, how about on your side? Just a couple of thumbs up. That's wonderful, Nicolette. Over to you.
Good, thank you. And thank you very much for this opportunity to chat to everyone today. So as Bronwyn said, I'm looking at living long with perinatal HIV. And basically from a physiotherapy point of view, what are some of the consequences or sequelae that adolescents are living with, specifically in terms of perinatal HIV? Next slide, please. So if we look at a poll here that I have put forward, I would be interested to hear from the audience which of the following statements is or are true. So the first one, early antiretroviral initiation eradicates developmental challenges associated with perinatal HIV. The second option, adolescents living with perinatal HIV face psychosocial challenges, but their physical function is on par with peers. Number 3, motor developmental screening throughout childhood and adolescence is recommended in the National Strategic Plan. Number 4, adolescents with perinatal HIV who have long-term viral suppression do not present with any activity limitations or participation restrictions. Or number 5, none of the above. Gabriella, I don't know if you want to run it as a poll through Zoom or if people just can give their answers in the chat.
I could give the answers in the chat if that's okay with you and Bronwyn.
Yeah, perfect. So you can just pop a number in the chat for which of the answers below are true. Okay, so coming in clearly with 5, nobody will dare put a different answer now when there's a majority. But we'll go through the presentation, and where you will then hopefully be able to see the nuances in each of the points, where initially, an initial read, each of the points above do look accurate or potentially correct, where in fact they are, none of them are. So option 5. Okay. Next slide, please. So HIV continues to be a global health challenge across the age spectrum, with approximately 1.7 million adolescents living with HIV globally. As access to antiretroviral therapy improves, so the cohort of adolescents with perinatally acquired HIV grows, with up to 79% of perinatally HIV-infected adolescents living in sub-Saharan Africa. Slide. Research is starting to show how this vulnerable population face unique challenges in terms of motor development, decreased exercise tolerance and physical activity, mental health issues, neurocognitive delay, stunting, wasting, delayed puberty, pain, and fatigue. Next slide, please. And while there are models of care available for people living with HIV, there are minimal models of care specific to fever, to perinatally HIV-infected adolescents. Most of the models of care for adolescent HIV focus on transition of adolescents to adult care and ART adherence. So although this unique population is growing, and we are learning more about the challenges that they face, many healthcare systems lack the preparedness needed to be able to deal with them adequately, and highlighting the need of a model of care that caters for these adolescents and their potential physical sequelae. Next slide. So based on these challenges and this gap, we undertook a study to determine the physical sequelae that fever face and to develop a model of care for the population. This diagram here shows overall in the middle the development of the model of care, but that it was broken into preparatory phases before that. So on the top left, phase 1 was a qualitative study that we did with interviews with fever, where we explored what their challenges were with living with perinatal HIV. Phase 2 was a quantitative cross-sectional analysis of fever with a variety of outcome measures that I'll go into detail on just now, where we assessed physical functioning. And then lastly, based on the findings of a scoping review and from phase 1 and 2, we put together the model of care, which was developed and then ratified through focus groups with clinicians and with adolescents themselves. Next slide, please. So I could talk for hours on this topic and on the study, and there isn't enough time today to cover all of the studies in detail. So here you'll see a QR code, and DTHF will also put into the chat the link, which is going to take you to our profile that has all of the publications, publication links available. And today I'm just going to give you a brief overview of the studies that emanated of the publications that emanated from the study. So looking first at the scoping review, we wanted to see what was available already on perinatal HIV sequelae in adolescents, and it resulted in 8 studies being identified. All of the studies were cross-sectional analyses. However, it was important to note that only 2 of the 8 studies used an HIV-negative comparison group for their data. And from the scoping review, impairments BMI, delayed puberty, physical functioning and activity, exercise tolerance and lung function, and pain. Next slide, please. The next part of the study was the qualitative study, where we undertook semi-structured individual interviews with 19 adolescents, looking to determine what the perceived challenges were that they faced. The mean age of the group of adolescents was 13 years, and all of the participants were virally suppressed and were therefore well managed in terms of their HIV. Next slide, please. We coded the interviews and found that the most frequent codes were poor endurance, pain, and fatigue, and with additional challenges around community participation, motor skills, and other emotional health and cognitive issues. So from these codes, categories were created, which covered you can see there in the dark orange, physical challenges, psychosocial challenges, and then other health issues, which led to the overall theme of living life as an adolescent with perinatally acquired HIV. Next slide, please. The second phase of the study was the cross-sectional observational study. So this included 147 HIV positive adolescents, perinatally HIV positive, and then 102 age-matched HIV negative adolescents who came from the same socioeconomic background as the fever. You will remember from the scoping review results that I had said only 2 out of the 8 studies identified had an HIV negative comparison group. And so it was really important for us in the study that we could address that gap that so many studies don't have a comparison group. And so that's why we worked towards getting the HIV negative adolescent comparison group. These participants were accessed through the research unit's database of family and community members, and therefore served as a similarly based comparison group. Sorry, Gabriella, next slide, and one after that. Thank you. So looking at the outcome measures from the cross-sectional study, we assessed fatigue using the HIV-related fatigue scale, and then also looked at their level of disability with the WHODAS, the World Health Organization Disability Assessment Schedule, which had items assessing understanding and communication, getting around, self-care, getting along with people, home life activities, school life activities, and participation in society. Their anthropometric measurements were taken through height, weight, and BMI. Endurance was assessed with the shuttle run test and muscle power with the broad standing jump. And then the movement ABC was used to assess motor performance through manual dexterity, aiming and catching, and balance. And I think everyone in the audience who is not a physio or an OT is probably wanting to run a mile. But these are all of the different components that we would look at in terms of the physical functioning and how the adolescents are able to perform in their daily activities at home and at school. Next slide, please. So from the 249 adolescents that were included across the 2 groups, we found that both groups were equally overall well managed, with the vast majority at 87% being virally suppressed and a mean age of ART initiation of 8.5 months old. So very early ART initiation, diagnosis and initiation. Next slide, please. Looking at the results from the anthropometric values, the fever scored lower compared to the controls, with their height, weight, and BMI all being significantly less than the adolescents living without HIV, and significantly more of the fever were stunted and wasted compared to the control participants. Next slide. Table 7 shows that on the HIV-related fatigue scale, the fever showed a significantly greater fatigue intensity compared to the HIV-negative group, but there were no significant differences found between the 2 groups in terms of the peripheral neuropathy frequency. Next slide. So with the exception of the shuttle run test for endurance, the fever performed poor on all outcome measures for physical performance, with significant differences between the groups for the overall movement ABC scores. So you can see the p-values involved there are for the significant differences. While the differences in endurance and muscle strength between the 2 groups did not reach statistically significant differences, it was noted that both groups performed far below the expected normative values for their age, all scoring in approximately the 25th percentile. Next slide. So this slide shows the results of the disability assessment using WHODAS. And on this, we see that the fever scored significantly worse than their HIV negative group for their total score, as well as for subset participation, showing that disability is a substantial problem in this population still. Next slide, please. So with the data from the qualitative and quantitative studies, as well as the results from the scoping review, we drafted a model of care for fever using the ICF as a conceptual framework. This was then ratified in the third and final phase of my PhD through focus groups with adolescents as well as clinicians of different professions. For the interprofessional group, we used purposive snowball sampling to identify a variety of healthcare professionals that work with adolescents with HIV across multiple clinical sites. And we an input of clinical experience from different sites for the professional group. Next slide, please. So over here, you can see the final diagram put together in terms of the model of care, and I'll go through the schematic with you as well now. There, the importance of all the interprofessional healthcare that came through in terms of the interviews and the focus groups, and then the different physical sequelae that fever faced or can be encountered were divided across the impairment, activity, and participation domains of the ICF, which you can see there in white in the middle, and then with the previous two study phases and the scoping review informing the likelihood of moderate versus high risk, which is indicated through the red or yellow. Next slide. We also created a more user-friendly version of the model of care, the schematic, and this was created for use in general public education, where we have our adolescent at the center, and then the different potential sequelae swirling around them, and then finally the team of healthcare professionals on the outer layer surrounding the whole adolescent and the situation in which they are living. Okay, so in summary, what we found out of potential challenges with pain, decreased endurance, fatigue, stunted growth, decreased motor performance, and higher levels of disability. What is really important to note is that the HIV positive participants that were part of the study all had a young mean age of ART initiation. Percent of them were virally suppressed, and yet they still presented with significant impairments, which leaves one to consider the health. We already know that younger children living with HIV experience disability, and many of these challenges, and many of the challenges mentioned already. However, the results of the study highlight that this continues through into adolescence. Next slide. So what is the way forward? The adolescents from the study were from a well-managed cohort that had been followed since birth with regular assessment, with regular assessment, management, and follow-up in a large urban clinic. I would love to be able to expand and replicate the cross-sectional part of the study into other sub-Saharan African countries and into rural South Africa, to be able to see the prevalence in these of impairments in adolescents who are potentially not as well managed as in the study. This unique population also needs comprehensive and holistic management, and standard clinical practice should include regular screening and interprofessional referral for further assessment and management as needed. And that's where I hope the model of care can come in and be used as a tool to assist with this. So thank you very much to everyone for listening. And on the last slide, Gabriella, if you can move forward 2 slides, you'll see that where I just want to take a moment to acknowledge the co-authors and supervisors of the study, Professor Veronica Nsia and Joanne Potterton, as well as obviously the involvement of all the parents and children and staff at the research site and my funders. So thank you very much, and thank you for today's opportunity to speak to everyone.
Nicolette, thank you so much. I don't know if it was just on my side, colleagues, maybe on your side too. There were just a few moments where the audio cut out. Perhaps it was just on my side. So if possible, perhaps, Nicolette, we can also share your pre-recorded version with audience members, unless, of course, that was just on my side. But thank you very, very much. Colleagues, so we're just almost at 3 o'clock, which means we have a nice chunk of time for our panel discussion. And yeah, we're going to move straight into the panel discussion. And before we do, I just wanted to say that for any of the audience members that wanted to contact or make contact with Dshamilja, that they can just contact Gabriella and she can do sort of an introduction for you, for those of you who would like to connect with our artist that presented this afternoon. So just a reminder on that. So allow me to introduce our three panelists. And firstly, we have Professor Lesley Gittings, who is an assistant professor at Western University's Faculty of Health Sciences in Canada. Lesley's joining us this morning from Canada, so it's probably just closer to 9 o'clock now, I'm sure, Lesley. So, you know, starting to wake up and enjoy the day, although you've had a very busy morning already. And she's also a research associate with the University of Cape Town Centre for Social Science Research at the Adolescent Accelerators Hub. And so her predominant research focus area is on the social and environmental determinants of HIV and sexual and reproductive health among adolescents in Africa and Canada. And secondly, we have Theresa Mapfuti. Welcome, Theresa. Nice to see you there. You have a wonderful background going on there. I was quite distracted by the beautiful artwork. So Theresa started as a recipient of care and then worked as a peer counselor known as Community Adolescent Treatment Supporter, or CATS for short, for 5 years with the Zvandiri. And as a CATS, is that how you refer to it? As a CATS, as a community adolescent treatment supporter, she gained experience in the service delivery, implementation, and capacity building of HIV-related programs, and strengthened the quality of services provided by healthcare workers through training around provision of adolescent and youth-friendly services. So currently, Theresa works as a primary counsellor within the Ministry of Health and Childcare in Zimbabwe, and services with the Zvandiri board representing the voices of adolescents and young people within Zvandiri. So welcome to you, Theresa. And lastly, we have Dickson, Madzivadondo, who's a 19-year-old young person from Cape Town living with HIV, who is joining us this afternoon to share his thoughts and experiences as well. So welcome to all our panelists. Thank you so much. We are very much looking forward to this section of the presentations this afternoon. So panelists, if I may, I can see all of you have your cameras on. That's wonderful. I think now would be great for us to perhaps go sort of in a round robin type of fashion, where we give each of you the opportunity to comment on the presentations made by our speakers this afternoon. Lesley, you yourself formed part of the first presentation. I think, given that I've also sort of introduced you first this afternoon, perhaps we can go in that fashion. Perhaps we do Lesley and then Theresa and then Dickson, and then we can sort of go whoever has a comment or question after that as well. For our colleagues online, this will also be the part where you can absolutely populate the chat with your questions and comments, but also we will unmute you at this, or give you the opportunity to unmute yourself at this point. So if a gap arises, please do feel free to join us in the panel discussion this afternoon with your comments and questions too for our two speakers. So Lesley, perhaps you can start us off.
Great. Thank you so much, Bronwyn, and it's wonderful to be here. Thank you, everyone, for the opportunity and also your questions in the chat. Bronwyn, I just wanted to clarify. So your first question was just a comment, really? Is that right?
Yeah, so if you have any thoughts or comments, so I know you formed part of the first presentation, perhaps you'd like to share some additional thoughts, maybe on some of the comments also that came up in the chat for you. And then any thoughts on Nicolette's presentation as well.
Yeah, absolutely. So I think, and I'd love to hear from the other panelists as well on this, but my first thought is really around what does it look like to thrive? And specifically what I'm thinking about here, and Nicolette, I'd love to hear your perspectives. You know, we're talking broadly about physical health outcomes and also more broadly quality of life, as well as
provisions to really support thriving across multiple domains. And I was wondering, just a little bit, I'd like to hear from all of the panelists as well as Nicolette about, are there any provisions and supports that you have noticed have worked across multiple physical as well as social and emotional and broader well-being domains when we really think about thriving?
Thank you. I'll keep an eye on the chat, but obviously I don't want to jump in and respond if others have. In terms of perinatal HIV in adolescents, that because it's really only now that a lot of the research is only starting, I think a lot of the interventions and support still needs to come through. And as far as we are in the HIV pandemic, that there's still so much that needs to grow and develop. And I think that the support to the adolescents or perinatal HIV in adolescents, because of the timeline for them now growing into adolescence and into young adulthood. And that's what I found also particularly noteworthy from your presentation, was that in the 4 years that were followed through in the first part, where there was only 38% adherence, after 4 years. And that's so hard in terms of still having to struggle against adherence, as well as all the other issues that we discussed now. So to answer your question briefly, no, I don't know what the perfect solution is or the golden answer is in terms of support. I think that more and more awareness that can be created in terms of the healthcare teams, as well as the adolescents and caregivers themselves, the more awareness that can be created, hopefully the better progression we get from there. But for now, certainly just in the clinical side where I did the study, one of the really useful and helpful techniques that they used was a social support group that used to run on Saturdays with adolescents themselves, where they formed their own peer support group. And there was a social worker around to facilitate or to answer questions if it was needed, but most of the time it ran independently by the adolescents who would attend the clinic, and specifically being on a Saturday, that they weren't missing school and extramurals and falling behind in their subjects that they're studying to come through to the group or to collect medication. So that certainly had a lot of positive from the clinic themselves, but that's my anecdotal answer. It's not based on anything that I've done further.
And Lesley, would you like Theresa and Dickson to share their thoughts too on that?
Absolutely. Especially I'm just thinking about Theresa's amazing work as a cat, and thinking about that model as well. Any thoughts? And Dickson, absolutely.
Theresa, would you like to go ahead? I see Theresa's put her camera off for a bit, so Dickson, go ahead.
I'll try. One of the things that I've noticed is probably how most people don't really notice how hard it is to sometimes hang around people, especially when you go around, let's say it's your clinic day, you need to go to the clinic and to take a medication. They don't know how how you have to skip school sometimes, because sometimes you have to skip school and no one really knows why you skip school. Sorry. So, and a lot of people ask you, maybe your friends ask you, why are you always skipping school? Why are you always leaving without us telling us why you're leaving? And you can't really tell, because, and there's a lot of stigmatization about how you got it. No one really believes that you can be born with it. They only believe that you can be contracted from other people sexually or in some other way. And that's also a very hard way of how people sometimes go through depression, is how they're scared of even taking the medication anymore. What's the point? I'll be living like this for the rest of my life. And it's that point, some people just don't care anymore and don't take the medication. That's why that's my thoughts on how after 4 years, maybe you're now 16 years old. Back in the day, your parents are the ones who make sure you take medication. But now you're older, they think you're responsible enough to take it yourself. But in actual reality, you're actually scared of taking medication because you're scared that I won't be like everyone else. I'm specifically on my own. What if my parents are no longer with me? Now I have to live with this like burden for the rest of my life, take medication every day. And sometimes it's not even your fault. You can't keep, some people, you have a lot of things going on in your life and you maybe forget that you need to take it, or you just forget that you need to take it, or you forget that that it's important to take it every day. Even if, because let's say you live to this for over 18 years now and you see no problem, you think maybe stopping a week won't hurt, but it actually does impact you, and you only figure it out when it's too late, once you're already sick. And having people talk to actually really does help, especially someone with it. Because if you can have someone who has the same experience as you, you might have something you can relate to. Except talking to a counselor is hard because they can't relate with you sometimes. All they can do is just look at data and think that's how you feel. But in actual reality, most people are hard. It's hard to tell the truth sometimes. And some people just tell you what they want you to know instead of what they actually feel. That's why you see most teenagers, their adrenaline goes down after maybe a few years of them taking it. Not because that they don't want to, it's because they're scared of taking it anymore. That's my views, but thank you.
Thank you so much, Dickson. Lesley, did you want to share some thoughts on Dickson's response?
Dickson, thank you for that really thorough and important response. I guess there's a few things that I'm really sitting with, and going back to the poll right at the beginning around stigma and how stigma might sit different at different times in life, especially when you might not have that same caregiver support. And I'm wondering about transitions into the clinic and still attending the clinic and taking pills when the caregiver support changes. Also, I thought it was a really, really important comment on mental health and the importance also of other young people and peers. And that's something that I'd love to hear also a little bit more from Theresa about. And then I think the last thing was, Dickson, I'm just really reflecting on is the meanings of medication, how medication can also take on different meanings of a reminder of maybe feeling different. And if there's any kind of social supports that you've noticed, or Theresa in your work as a CAT, that can be used to support and buffer against some of those challenges around some of those meanings and negative meanings of medication. Oh, Theresa, I think you're on mute.
Okay, sorry, I was having technical challenges, so I did not get the question correctly. That's why I was on mute.
No, that's okay.
Maybe you can come again.
I'm wondering about your experience as a CAT, and what you've noticed about the possibilities as well of providing support from other young people living with HIV, and what you've noticed, if that's helped with any of the things that Dickson mentioned around stigma, feeling not understood, feeling alone. Does that make sense?
Yeah, that's very true what Dickson was saying. Like some of the peers, they really know, they have information and stuff, but they tend not to take their medication well because of that, what was Dickson saying. And as for my experience, I've managed to see many of those kind of peers facing those difficulties. So as a case, like I'll be helping them to come up with the great ideas, like even to know the importance of their medication well, so that they can achieve their goals. But really, for sure, in adolescents and young people, we really face those challenges. Dickson was saying all of them.
I think, Theresa, your microphone switches on and off somehow. Some ghost in the machine. Right now it's on mute. There we go.
Yeah. So I was saying, yeah, most of the adolescents, they fear to go to the clinic to get their medication, like especially on transition. It would be not easier for an adolescent to sit with the adults, because you want to feel some of the caregivers, they might judge you. They might think you get HIV from a partner, not knowing I was born with it. So some of the adolescents, they won't feel comfortable to go to the clinic because they might fear stigma from the caregivers. Whilst those caregivers are also HIV positive, but they won't be able to understand that I got it from my parents, Or it's sometimes, again, it's because of the attitudes of the nurses. Some of them, that they won't have information. They might start to judge you. Like when I want to receive a medication, they might start to say a lot of things about you. Or maybe I got an STI, then I want to get treatment for that. So they will start to say a lot of things. Because I'm HIV positive, yes, I have got an STI, they start to talk a lot of things. So you might also say, like, us as adolescents living with HIV, if we have any other challenges like STIs, we won't be able to go to the clinic for medication assistance because of fear. Yeah, maybe I guess it's okay.
Dickson, I know that you might need to leave soon. So I wondered, with the experience that you have and the comments that you've shared, especially around sort of the fears that adolescents experience a little bit later on that impacts on their adherence. What, in your opinion, is the way in which we might assist to try and rectify some of these issues? What are the supports? What are the gaps? What is it that young people need that might help to address some of these fears and concerns? And where should this support take place? I've heard about support happening in the clinics, but should the support happen somewhere else outside the clinic, in the community? How do we go about this? What are some of your thoughts?
Hey, one thing I've noticed is that most of you don't actually understand something about having to share based on, let's say like you guys went to schools and tried to help children with that. That would be a problem because I wouldn't be comfortable going somewhere just knowing that people know where I'm going, knowing why I'm going there, because I don't want everyone to know, because people share a lot of thoughts. In school is a huge place for discrimination and a large place where you don't want to feel different. You want to feel the same. That's why most of the time I think you should keep it where it's isolated, where you can keep it where people can relate. Because my personal experience is when I actually, the first 15 years of my life, I actually didn't know I had it. I only found out about when I was 16. After my parents, after going in and out of clinics, in and out of hospitals, not even knowing that I had it. Only hearing my school talking about it, sharing about how you can prevent it, and only finding out that I also had it when I turned 16. Only then, even though I was born with it my whole life. And even though, because I think telling a child when they're still young, it's easier when you tell them when they're older, because it'll be easier to register when you're young, because now you live with it. Now you know that you control it. Because only telling a child when they're older it's hard on them. Because I also felt hard when I only found out. I even went through a rough stage of my life where I actually wanted to stop taking medication completely, to try to protest against it, saying I don't need this. I'm not different from everyone else. I want to be the same as everyone else. And that did roughly affect me, and I went sick for a whole year. But I managed to push back, but now I understand how it's supposed to work. And one thing I also know is that talking to someone like a peer who goes to the same clinic to you, like someone your own age, someone who's affected with the same, helps a lot, because You get to share with someone who can relate with you, someone who you can even laugh with, instead of talking to someone, let's say a doctor, who only knows medical information about it, who only knows something book to book, but can't relate with you both physically and mentally. So talking to someone, even though counselors are there, they don't actually help, because when you talk to a counselor, all you do is tell what the counselor wants to hear, and then they'll be over, and then they'll leave you, and then they just let you go. But it doesn't actually help anything, because you know yourself, you lie to them just so you can get out of that room to go home to get rest. And also, young children, like teenagers, go through a lot. I can promise you that. They're already going through their own emotional, going through relationships and like that, because when you know that yourself is affected, sometimes you feel you can go into a relationship because you see all your friends or your peers are with different partners, while you yourself is scared because you might affect someone or infect someone you fear. Some actually don't even care and say, I'll infect them so that they can be with me forever. And usually that's a bad thing, because you know how that can affect someone's life forever. And it's a burden which will affect them for life. So in my opinion, helping them both emotionally would definitely help them to take medication better, because the better a person is emotionally involved, the more physical they want to be involved too. Thank you.
All right, thank you so much, Dickson. I know that you need to probably leave, so if you have to go, thank you so much for joining us here this afternoon and for sharing your thoughts and wisdom. And even in the short amount of time, I think those of us that have been listening are really sort of alerted to what young people's needs are in this instance, and how we can sort of, if anything, listen more to what young people need in an attempt to address or help address some of those challenges. So thank you so much to Dickson. He has to leave us this afternoon, so we can go back to our other panelists, Lesley, Theresa. Theresa, would you like to share any sort of thoughts that you had as you were listening to the two presentations? What came up for you in the presentation with Professor Toska, and then with Dr. Comley-White that is joining us here this afternoon? What thoughts came up for you during those presentations?
As for me, like what I've noticed, some of the presentations that she was doing, as for me, I've managed to experience it. Looking at the weight thing and the height. Like for myself, for my height, I'm very short, So I guess it's true. It's really affect us. Like even talking like from what Dickson was saying in terms of stigma. At school, like when you're at school, people will be mocking at you, saying a lot of things about your height, think that you are a little person. Even like when you're walking, they say this child, they are very little, not knowing I'm a grown-up person because of my height, So it really affects us, And then there's also issue of weight loss again. Some of our peers, their weight loss, it really affects them. Like if you go to the clinic, and then you're not gaining at all, they start talking a lot of things, saying you're not eating, you're not doing well, but you'll be doing everything. But it's just that if you don't gain weight. So it's some of the things that are affecting us. Yeah, maybe I was just wanting to add on what Dickson was saying. Like I would think at schools they need more trainings if it's possible, like to both teachers and students. Looking at my experience, like myself, what I experienced at school, I used to face stigma both at primary and at secondary school because of my health condition. It was very poor. So I did not manage to enjoy my school life, because of that. Some of the children, they start mocking you, calling you names because of you're always sick. And when you miss school, going to your clinic for your review, then the next time you go back to the school, the teachers start beating you, like, even, why didn't you attend my lessons? Why didn't you come to school because of this and that, So for me to tell him or her that I went for my review, I'm HIV positive, it will be difficult because I don't want him to know my HIV status, you know. And as for me personally, also I wasn't able to do any activities at school, like sports, you know, because they said, as for you, you can't do anything, because if you do anything, you might fall for last and die because you're always sick, you know. So I guess if it's possible, I don't know how it might work. I guess like at schools, there's need of a lot of things to be done, like trainings or awareness, so that they can really know that being HIV doesn't mean you can't do anything. You can't run, you can't do any sports you want, you know. Then there's also at home, families, you know, some of the family members, yes, you might not take them that we're HIV positive because we all fear how are they going to treat us. Yes, for me, I was really, I really faced a lot of stigma at school and at family. So I don't know how can we make it possible for some of our family members to have that knowledge, you know, that information about HIV. As for me, I've managed to overcome it because after becoming kids, I was able to become a person who's able to accept anything because of my HIV status. But I know somewhere there are a lot of adolescents who are not able to accept stigma because it's a difficult thing to some of us. They won't be able to come up they won't be able to be strong to fight it. So it will damage them mentally and emotionally. So I guess there's a lot of work that needed to be done.
Yeah, thank you, Theresa. Nicolette, would you like to share any thoughts about what Theresa spoke about?
Yeah, absolutely, Theresa. Thank you. You know, just for sharing some of your experiences there. And I think that, you know, really.
Oh, Nicolette, your sound seems to cut out. Is it just me, colleagues? Is it just are others experiencing the cutout? Okay, I don't know what it is, Nicolette. Sorry to interrupt you like that.
No. I'm glad you told me. Can you hear me all right now?
We can hear you perfectly, and then it's sort of seamless. And then in these, it seems to interestingly happen at the most crucial bit of your comment.
The computer gremlins. All right, let me try, and if not, then I'll type up my answer in the chat. I just wanted to say to Theresa that, you know, just hearing what she shared is really similar to many of the other adolescents that I was chatting with.
Oh, it cuts out there.
About school and not attending with sport, and that participation, you know, health gets measured by blood test values, looking at CD4 count and viral load, and then tick medications working. But what about the levels of disability, the participation, the quality of life, all of those components that are so important and, you know, are the foundation of growing up and adolescence, and that often falls by the wayside in terms of clinic and screening. So Theresa, you know, said what can be done. It's a big job, but it's about really continuing with the education of schools, of healthcare providers, of families, communities, of everyone that is involved, to try and to allow for that participation, allow for improved quality of life, and then to advocate when we see there are gaps and spaces for, using your example of participating in sport, that we are able to advocate for learners at school to be able to take part in the sport and to be involved. But it is a huge job that every single person has a role to play in.
Thank you so much, Nicolette. Lesley, I'm not sure if you've got anything you'd like to add at this stage.
Well, really just to thank Theresa very much for sharing your experience so openly. And also it's really got me thinking quite a bit about what does holistic support mean? You know, if there are these different issues, stigma, mental health, being discriminated at school, having trouble getting to the clinic. And Theresa, I just wanted to come back one more time to the important work that CATS do as well. And if in your experience, are there certain places that CATS really support? Is it at the clinic? Is it in home? Is it with mental health? Is it at school? where do you see the role as cats being most powerful? And are there any other areas that you think they might support?
Okay, as kids, what we do home visits. We'll be visiting our other peers. We'll be monitoring them on adherence. We also do support groups where we'll be facilitating the support groups. We'll be having many children that will come to the support group. Then we have different activities. Like that's where we also share our life experiences, because somehow, an adolescent won't be able to understand what we'll be saying, but if he or she hears from someone life experience, it will make it much easier for them to understand. So we also work in the hospitals and clinics where we meet those who come to clinic for their art supplies. That's where we talk to them. We monitor them on adherence. We also link with them with other peers. So we are just there to support our other peers in the community so that they won't feel alone, or they won't feel that they are going through a lot alone. So we are here to support them and make them meet with other people, with other peers of their same status.
And Theresa, I just see a question in the chat there. So would you be able to tell us what CATs are? It's a form of peer support, right?
Yeah, like they are more like peer counselors, because it's work as in peer-to-peer. Are you answered well?
So thank you to Theresa and Lesley, as well as Nicolette. Colleagues, I see that there are some comments in the chat. Hopefully people have had a chance to read through. There's people advocating for some of the services happening in the afternoons that might be helpful for young people, and also a comment about the support received through Desmond Tutu in terms of medications, and that experiences of doctors have not been as great compared to that of the Desmond Tutu Foundation. Then I also noticed that there are some questions by Margaret and Jessica in the Q&A. And Margaret says, is the 4th and 90 attainable for adolescents, and how best can health care providers support adolescents to achieve a good quality of life? And I think we've had some discussion of that just through the panel this afternoon, Margaret, that hopefully, shed some light on that. But I think it's from what we heard from Dickson and what we hear or what we read here in the chat, I think there's still a lot of work to be done on the part of healthcare providers to understand more about, as Lesley said, it more about these domains of well-being and these domains of quality of life, and understanding what that means, and using that then as a platform to try and do better. I think I think many healthcare providers will probably feel that that a lot that in their opinion is being done, but clearly we can do more to support that. Lesley, what are your thoughts?
I think it's a great question, and I wish we had an answer, because if we did, I think we'd be living in a much more equal, healthy world for all. I do think really focusing across those domains is important, and there's some areas where we do have evidence. For example, we know that not getting yelled at in the clinic, feeling respected and not stigmatized makes a big difference. We know that peers and models like CATs work and can provide linkages and wraparound care that's needed. We also know that it's really important to make sure that folks have their livelihood needs met and their economic needs met. People and children living with HIV, there's an evidence on this. If you're not food secure, it's really tough to take medication. If you're not water secure. So I think we need to also broaden the conversation to look both at the physical aspects, which Nicolette so importantly highlighted, as well as what does wraparound holistic support across psychosocial, as well as economic and structural aspects look like.
Thank you, Lesley. I do see a hand by Luckmore. I do just also have to say that an important role that I have as chair is to monitor the time, and we have gone half past. So Luckmore, if you would like to just quickly have your question or comment, you can unmute yourself. All right, I'm not getting anything from Luckmore at this stage. Then there's also a comment by Jessica about palliative care to adolescents. Thank you, Jessica. I note the question there as well as the reference to the paper and the online readings. So thank you for bringing that to our attention this afternoon as well. So colleagues, it is my job now to bring the webinar to a close. And so I would like to just thank everybody for attending this afternoon, for your interest and your questions, and to our panelists and our speakers, thank you so much for your time. Then also to the Desmond Tutu Health Foundation, as well as IAVI for sponsoring this event. And for those of you who might be interested in understanding more about the IAVI Fellowship, to please make contact with Gabriella, perhaps for the link. Although I can also actually just quickly paste this link in the chat for those of you who might be interested. And then also to our artists this afternoon for sharing their poetry. And please, for those of you who would like to make contact, please also contact Gabriella in that regard. When you exit the Zoom platform this afternoon, you'll notice a brief evaluation, and we would so appreciate it if you could complete that for us. It does help us to improve the webinar series in the future. This session, as all of you know, has been recorded. It will be available on the Desmond Tutu Health Foundation's YouTube channel, so you can access it again. I think it's something that I'll definitely also want to listen to again. So thank you, everybody, for joining this afternoon. Keep well. And have a wonderful week further. Thanks, everybody. Goodbye.